Okay, if necessary, I'll move the cameras. Are we good to go?
People are coming in.
Okay, and you want me to share my screen, or you're going to keep this screen?
I'm sharing mine.
Perfect.
Hello, everyone. Welcome to Webinar Wednesday today on December 6, 2023. My name is Melissa Haddad, and I will be your host today. The Durham region exists on the lands of the Mississauga and Anishinaabe, inhabited for thousands of years prior to European colonization. These lands are the traditional treaty territories of the nations covered under the William Treaties, including Mississaugas of Scugog Island First Nation, Alderville First Nation, Hiawatha First Nation, Curve Lake First Nation, and the Chippewa nations of the Georgina Island, Beausoleil, and Rama. We honor, recognize, and respect Indigenous peoples as rights holders and stewards of the lands and waters on which we have the privilege to live. In our efforts towards reconciliation, we continue to build and strengthen relationships with the First Nations, as well as large Métis communities and growing Inuit communities here in Durham. We commit to learning from Indigenous values and knowledge, building opportunities for collaboration, and recognizing that we are all connected. Please share in the chat the territory you are joining from. Today's webinar is Rejigging the Architecture of First Contact Care, Evaluating Virtual Care in Our System and Your Practice. This session is part of the Webinar Wednesday Healthcare Innovation Round Series and has been certified for Mainpro Plus credit. It is my pleasure to introduce Dr. O'Neill Bhattacharya. Dr. O'Neill Bhattacharya, MD, PhD, is the Frigon Lau Chair in the Family Medicine Research at Women's College Hospital and Director of Institute for Health Systems, Solutions, and Virtual Care. He is the lead for Center for Digital Health Evaluation and the Canadian Network for Digital Health Evaluation. He is also the co-chair of the Canadian Primary Care Research Network, funded by CIHR. He practices family medicine and is an associate professor in the Department of Family and Community Medicine and the Institute of Health Policy. Management and Evaluation at the University of Toronto, my apologies. He has been a Harkness Fellow in Health Care Policy at the Commonwealth Fund in New York City and TECME Fellow at the Harvard School of Public Health. Please note that we will have time for Q&A at the end of today's presentation, so please type your questions in the chat box at any point. Thank you for being here today. I will now pass the screen over to you, Dr. Oh my goodness gracious. Over to you, Dr. Bhattacharya.
Thank you very much. Okay, I'm just going to try the share screen, and hopefully it's going to go smoothly this time. And you're going to keep me in check here. See if that works. And start screen. Okay, well, are we seeing the right thing?
We are seeing your slide presentation, all the views, and your talking notes.
Oh, and my notes. Okay, and so apologies for this, everybody. I'll just be a second. So new share. Is that better?
We are still seeing the notes. There we go.
We're good. Okay, thank you very much. All right, good afternoon, everyone, and thank you so much for joining me today. And I will just give you a bit of an overview of the presentation that I hope to give. So let's see, make sure the slides advance. All right. So these are the objectives for today. The first will be to talk a little bit about first contact care, which most people call access, but it's the idea of, where does the public reach out to when they have a new problem. I'm going to talk a little bit about this being a Digital Health Canada talk about tools to enhance access to care. And though I did give a rather lofty, broad title, I want to do a deep dive on secure messaging as a key element of improving access, because it's something that's been a little bit less developed within our system. And then I want to close with a sort of conversation around how we balance the intensity of interactions to create the right type of access for our patients. Full disclosure, I'm a family doctor, so I will talk mostly from the point of view of primary care. However, there's a section of the talk which will focus on specialty care as well, and I'll try to keep it broad in those terms. So as was mentioned, I lead a bunch of digital health type efforts. So one is within the hospital where I work, Women's College Hospital. I help lead a series of evaluations of women's virtual, which is one of our major strategic initiatives. I do a lot of work with the provincial government here in Ontario through a program called the Centre for Digital Health Evaluation, so evaluating large provincial programs, and also work closely with the federal government and policymakers and researchers from across the country in something called the Canadian Network for Digital Health Evaluation. And it's a really important time to be not only evaluating within regions what's being done, because we're trying so many new things, but also evaluate across the country because so many programs that are similar are being rolled out at the same time. So I will try and bring in some of that comparative policy lens as I go. So let's start with some of the problems that we are facing in our system. And so this is from the Commonwealth Fund, as was mentioned. I did a fellowship with them. They do some excellent work looking at comparing performance of health systems across countries. So this is a series of questions from the 2020 survey. So percent of adults who have a regular place of care, you can see that Canada ranks relatively poorly at 90%, and these numbers have actually declined with reducing rates of attachment in primary care, in part because of higher rates of retirement, fewer people going into primary care, family medicine, as well as increasing population. Now, percentage of adults with a regular place of care for over 5 years is at 57%. So that's actually, when you think of care with access and attachment and continuity, that's even worse, but we're sort of more in the middle of the pack on this indicator. When we look at access in general, and this is a question, so these are surveys of the public, and they're conducted in similar ways across 10 different countries. And so this is the percentage of adults over 65 who waited 6 or more days for an appointment when sick. And in many, many elements of access, Canada ranks very poorly. So 31% of adults, had to wait 6 or more days, as compared to 4% in Germany or 5% in Netherlands, which are systems that really have invested heavily in accessible primary care. Next. The percentage of adults who sometimes, rarely, never hear back from regular doctor on the same day. And again, we are outliers on this, and this is a type of access I'm going to talk about a little bit later on in the talk. And the last bit of bad news is the percentage of primary care providers who report having after-hours arrangements. Here we're at 40% as compared to double that in Germany. So there's many aspects of access that at baseline are not good. And we're thinking, we need to think about how we can improve that, recognizing that we have high rates of burnout within the primary care community. So percentage of primary care providers reporting burnout in Canada is at 53% for those under 55 and 39% for those over 55. And these are at an all-time high, both on comparative terms compared to many other countries, but historically as well. So we've talked about access being poor from a patient perspective. We've talked about physicians being burnt out. So the solution is clearly not to work harder. The solution is to rethink about the architecture of first contact care. What is it like? What is out there? What do we have to offer the public? So a patient who has a problem, what can they turn to? Well, these are a range of things that are currently available. So emergency department is a perennial, and we are outliers in the use of the emergency department for minor ailments across, both across a range of high-income countries. There are newer services like Health 811, which is a rebranded, present in many provinces and used to be called telehealth. We have a large network of walk-in clinics. We have primary care providers who are providing comprehensive care in a range of models in different provinces. We have private virtual first models like Maple that during the pandemic were widely available and now mostly available to people with employer-based insurance. And in many provinces, we have increasing rates of use of pharmacists as a kind of first contact point for the health system. In Ontario, when we introduced prescribing for pharmacists in the last year, we had 400,000 visits for minor ailments. So that's a growing piece of what is available. But beyond just like the structures, we also need to think about the tools. What are the tools that we have to provide better access to the population? So in the management literature, there's this concept called the IT productivity paradox. And essentially what it posits is that there is a 10 to 20 year lag between massive investments in information technology and improvements in productivity. This is not particular to medicine or healthcare, but rather you can see in healthcare, we are actually maybe more of an outlier. When we look across a bunch of industries, when you look at industry growth and employment growth and increases in labor productivity, we are on the low end. So education is an even more labor intensive and less kind of IT enhanced kind of discipline than ours. But we essentially have had, in the last 20 years, made substantial investments in information technology, but not seen massive investments or not massive increases in productivity. It's not to say that it won't happen, but there is a delay and it depends on what you do. So one of the main things that we've noticed is the introduction of electronic medical records, whose impact on one hand was to distance us from patients. So we spent a lot more time looking at a screen and a lot less time looking into a patient's eyes. And the second is that electronic medical records have introduced a substantial administrative burden that has contributed to burnout, among many other things, the high rates that I just reported on. So how do we get over that hump? How do we get past that 10 to 20 year? Because really, we're about 15 years out from some of the major investments, but we have not yet seen massive increases in productivity. So how can digital help us do better? We need to build better tools and we need to reimagine the work. It can't just be creating electronic versions of our paper processes. We need to think fundamentally about how the work could be different. So what are the tools at hand? There are a wide range of them, but I'll talk about them in terms of communication channels. So when you think about, this is a term, channel management is a term that comes from marketing. And, for 20 years, they've been talking about how do we engage consumer or clients and consumers through using a wide range of communication channels to achieve whatever their goals and our goals are. So in medicine, we're kind of new to this, but we definitely got a big boost in March of 2022. And so when you think about communication channels, there's two parts. One is time and one is the medium. So in terms of time, there's the scheduling parameters. Are we setting up channels that are incoming from patients, outgoing from providers? And are these interactions synchronous, asynchronous, or undefined? And then in terms of the media, you've got text, image, audio, video, notifications, and obviously in person, which was a staple, and it is, probably has increased again after dipping during the pandemic. But now essentially we have all of these channels at our disposal, and we just need to learn how to manage them. When we think about channel management, one of the questions, I've been doing research in this area for quite some time, and for a long time it was kind of seen as a nice to have, it's something we should do one day. But during COVID, it became very clear that there is actually a responsibility here. Here's a quote from a patient that we interviewed during doing a study for the ministry. I think it's more of an ethical obligation on both sides to use the most appropriate channel for the most appropriate situation so that the costliest and most resource intensive and most humanistic channels are there for the people who really need it. So I want to use that as a framing so that as we think about access, as we think about what we provide to patients and the channels we use, we keep this in mind. So I co-chaired a committee for Ontario Health on the appropriateness of virtual care in primary care. And as part of that work, we did a review of the literature. We reviewed 219 studies going up to 2021, and each study compared virtual to in-person care for a range of functions. So notice I'm using the word function here, and not just saying, oh, is it good in general, but it's good for certain uses. And so we looked at 5 broad areas. One was triage, and we found that virtual triage was safe, led to fewer in-person visits, but it was unclear the impact on efficiency, particularly whether it was done by a nurse, nurse practitioner, or doctor, and there's still more work to be done. But I think it's safe to say that in-person triage, while effective in some ways, is probably not going to be the norm, and that much triage, even patients calling in for an appointment to figure out when they need to be seen, much of that will be done, at a distance. There's a series of studies on general primary care, which surprisingly showed similar efficacy for many common diagnoses. So there's a reasonable literature to say many things can be managed virtually, and I think even though we may have gone a bit too far during the pandemic, I think there's a higher level of comfort with this now. In the literature on minor infections, we found higher antibiotic prescribing for some conditions and lower for others. So that was kind of variable. For chronic disease, you had higher rates of follow-up virtually, probably due to the convenience, and variable rates on control. Many of these studies were a little bit older, and some of the practices may have changed. And then lastly, for counseling, a very large number of RCTs showed comparable results for counseling in person or virtually. So if you think of these as core functions of primary care, triage, managing a wide range of conditions, minor infections, chronic disease, and counseling, much of this can be done virtually and will continue to be done virtually. And it's all essentially a question of what we do in person and when. When we look at patients' preferences, and this is taken from 2021 surveys conducted by Canada Health Infoway, you can see that there's a number of visit types that patients would like to have in person. Annual exams, certain types of screening, mental health in some cases. And then there's a series of things, follow-up of a health problem, minor health problems, prescription renewal, that they would rather do by other modes, either phone, video, or other. So obviously, we need to think about the function and the visit type and patient preference when we set up how care is provided. Now I want to talk a little bit about first contact care. So first contact care essentially refers to where do people reach out when they have a new problem? So in a primary care practice that is comprehensive, getting first contact right would mean essentially allowing people to log in, call in, or walk in and do a range of things, check symptoms, have an online consultation or some kind of triage that could be automated or manual, be directed to the appropriate person in a primary care team, either get a direct response or get online appointments booked, either face-to-face, phone, or video, and then some kind of internal process where people may be sent either directed to self-care pharmacy or the emergency room through a range of modes. So this is taken from a diagram developed in the NHS in the UK. And this question of checking symptoms and signposting is an interesting thing. Because that's not a function that historically was very well developed in our system. Now I want to talk a little bit about the needs of the general population and a different version of it, first contact. This first contact is essentially the first contact to a comprehensive primary care practice. And now I want to talk about first contact more at a system level. So if we think of the general population, there's a subset of people who just need, who have a range of health needs. Some of them need self-help and general information. Some of them, if they had access to some kind of automated triage and diagnoses, they would be able to be directed to an appropriate course of action. Some people need administrative staff because they have some kind of clerical concern or a form or so forth. Some people need access to allied health. Some other people may need access to a nurse practitioner or a pharmacist to have a minor prescription. Others need access to a family physician or a specialist. Now, this could, all of this can be offered virtually to some extent, but you need a bit of a toolbox, decision support tools, maybe access to records or remote monitoring tools in order to support these functions. So now I'm going to give you two versions of what this would look like, this kind of high level first contact, or you could call it a digital front door if you wanted to. So in Ontario, they've launched Ontario Health 811 that has a series of services when you go on the website. So health service locator and a medical terminology library that's just on the website that you can sort of self-serve. It has a symptom checker that you can input your symptoms and it gives you a preliminary diagnosis or a differential and recommends some course of action. You have access to health system navigators by either phone or chat. You then could go up to a registered nurse by either phone, chat, or video. And increasingly, we're offering, there's a new service called Episodic Access to Virtual Care, which will give people access to a nurse practitioner by phone or video, and then potentially onto other resources. So if you think about this as a kind of front-loaded system where a lot of the web-based and self-help stuff is offered, in BC, they've developed more of a back-loaded system where you have people can call, speak to a health system navigator or a medical office assistant. They can get access to a registered nurse or dietitian for certain types of support. They can get access to a pharmacist to get a medication renewals or during COVID, a COVID prescription. And that can be escalated to a family physician or a specialist with a range of other real-time virtual supports. So these are two ways of thinking about the massive demand for health needs that are very hard to meet in comprehensive primary care currently, based on rates of attachment and the structure of our services. So if we come back to managing communication channels, and now I've given you a bunch of additional kind of channels that are centralized at a provincial level. Now I'm going to talk about a particular one that is not widely used, and that's text. And you'll see why, I'm going to talk about this. But text is an interesting tool because it is very attractive to patients. We did a survey in 2008 of our waiting room, or patients in our waiting room, and the number one thing they wanted is an online appointment booking, and the number two is that they wanted to email their doctor. 14 years later, this is still not a common thing, but still something people want. So what's good about messaging for patients? I think it's pretty obvious. No need to make an appointment. You can respond to questions thoughtfully. You can reread messages, look things up, and obviously keep your doctor up to date, send information as needed. What's good about it for providers? Well, depending on how you set this up, you could standardize and automate elements of your history. You could automate and tailor elements of the treatment plan and education. You could use time as a tool for diagnosis, because you can check, it's very easy to check in with people, either looking at updated photos of a wound or repeat symptom scores, different ways of getting information from them. You can seek help from others before providing an answer because it's asynchronous. And there's no transcribing because your note is already written. And that's a good amount of our work is actually just transcribing oral conversations. So that's the good side. We did a pilot back in September 2017 with the ministry in Ontario, where they introduced billing codes for voice, video, and text in primary care. And in that time, they used a government-funded platform. It ran for about a year and a half. And in that time frame, we recruited almost 200 doctors, 14,000 patients, and had about 14,000 visits. Now, keep in mind, this was voice, video, or text. All of these options were available through the platform. And interestingly, 77% of what was requested by patients was messaging, with audio being a small proportion, video minuscule, and sometimes a mix of audio and messaging. But often physicians went on to convert some of the audio and other things to a message. So what ended up being used was 89% of these kind of new visits were messaging. So this is pre-COVID, obviously, but there was, a tendency to shift towards messaging. Now, one thing I will say in the pilot, they didn't have a scheduling function, and that may be why, messaging was so widely used. In 2019, when we look at messaging, Canada was an outlier in international surveys where, when posed the question, your practice offers patients the option to communicate via email or secure website about a medical question. Only 22% of patients replied that they could in Canada, as compared to 91% in Sweden, and much higher. So we were outliers, prior to COVID. In 2021, when we look at the InfoWay survey, the survey was published in 22, but it was December 21 data from InfoWay. And it looks like about 2% of patients had a visit through secure email or messaging. So again, minimal use still on the patient side. For providers, you can see a range of numbers ranging from 20 to 45%, but relatively few patients accessing the service. Now, I don't want everyone to think it's all rosy. Messaging has been widely used in the United States without any billing. And the numbers were very good prior to COVID and have shot through the roof in COVID. And now messaging is actually a major driver of administrative burden and burnout in the United States. So there is, I want to give sound a note of caution. It depends how you use this, and you'll see in a bit more detail what I mean by that. So in Ontario, we have a series of provinces exploring secure messaging. In BC, you have a flat fee with a cap, only two-way asynchronous messaging, but in some of the earlier studies was on a relatively small scale. In Alberta, you have a flat fee with a cap for both one and two-way messaging, much larger numbers, and you've got platforms like BrightSquid and others that some of them are integrated to EMRs, some of them are on their own, but that's more widely used in Alberta. In Ontario, there's the pilot that I had discussed, but the province is planning to launch new billing codes for asynchronous messaging in 2024. And so watch for that, because there will be opportunities to bill for this modality. Quebec is just launching and looking at try to set up a provincial platform for messaging. And Nova Scotia had block fees, or a different billing model, on a fairly large scale through a single platform, which closed in 2020 because the vendor shut down and was not renewed. So, a range of activity in this space, but still nothing, very dramatic, except for the Ontario pilot, which is likely to be quite large. So what are these messages? I won't go into too much detail, but you can have information-seeking messages, information-sharing messages. A lot of it is administrative stuff. Sometimes it's prescription requests. There may be social things. From the provider side, you might be doing broadcast messaging saying, oh, please book a pap smear. You need to do this test. You could, there's different ways of broadcasting messages or providing guidance. You could be fulfilling requests and also passing things on, or even including request denial. So there's a wide range of messaging. When you think about how it's used, you want to think fairly broadly. Now I'm going to talk about the experience with messaging in my hospital at Women's College. We offered this platform, proffered patient-initiated messages through the EPIC electronic medical record from October 2019. And so you can see the numbers here. There's patient-initiated messages in pink, and then in the kind of green, patient message replies. And so everything was hunky-dory until sometime in November of 2020, deep in COVID. And then we started to see the numbers shoot up. And the numbers went up and then down and up again. And so quite a bit of fluctuation. And then you see a dramatic drop in around December 2021. And I'm going to talk about that in a second. But essentially what happened is that many clinician services were overwhelmed, and they asked for the function to be turned off. Now I'm going to show you a little bit about how this played out in different departments. So messaging is not one thing. Messaging is many different things, and that's why I want to come back to that idea of channel management. It's how you manage different types of communication. And one of the core things is to think about what is the clinical model within which you operate. Are you doing one and done kind of consultations the way they do in dermatology often? Are you providing ongoing care with a few touch points, maybe once or twice a year for patients with chronic conditions the way they do in rheumatology? And this is two services that were not happy with messaging and actually asked to have it shut down. You can see at this on this date, the volumes dropped, dramatically. There are other services like mental health, where they are providing ongoing care, and messaging was carried on for a much longer period. They didn't ask to turn it off till later in 2022. And then surgery is, providing a fairly intensive amount of interaction for a short amount of time. And this was a service that was never turned off for surgery because they found it very helpful. Now, part of the value of messaging comes from how you set it up. So what are the workflows? So in dermatology, you can see a patient sent a message, it went to a nurse, then it went to an admin and a physician, and then it could go back to the patient. Admin could respond, a physician could respond, and so forth. In rheumatology and mental health, the patient went to an admin and then it went to a physician and again back. But in both dermatology and rheumatology, the nurses handled relatively few of the messages. And so that was one of the points of concern. The other one, particularly in dermatology, was people continued messaging even after they were, consultation was done. So the type of administrative support you have is very important. In surgery, the vast majority of the messages were managed by nurses. Physicians saw very few messages, and as a result, were quite happy with how they played out. So what were the barriers to adoption here? So poor engagement of all users. There was no training for staff or patients on how messaging should be used. Physicians viewed it as uncompensated and onerous work, and there was lack of clarity on liability. Here's a message from a dermatology. Patient might be like, yeah, I saw you for this, but I also have this spot now. So what do I do about that? And you're like, well, this is not appropriate for messages, and you have to come in. And then you get stressed out because the picture is blurry. I can't see if it's skin cancer or not. Is it my fault if I miss it? Do I tell them to come in 3 months and it's grown or changed? So they saw this as a huge liability risk to progressing complete information that way. And these were all things that came up before we shut it off. So one of the challenges is like, what is the, how long do you make yourself available to a patient? And particularly for specialists, they would get messages for patients they couldn't book in because they're booking 6 months out. So they didn't actually have availability, and they were stuck with these kind of messages. There were clear value for patients and administrative staff, but neither were consulted in the decision to shut off messaging. So here's an administrative staff saying, so it's an hour or two in the morning just transcribing voicemail. Then you're looking up in Epic in the electronic medical record, all the information, and you're making a call back to the patient, whether they're there for their voicemail. If they don't have voicemail, then you're calling the patient back. Patient didn't understand, so they're calling back. So it turns in a much longer process than just looking up the message and typing it back. So clearly messaging has different value for different types of people. These have important implications for how you roll it out. So the last thing I'll say on messaging is that it is not one thing. In the States, they've been doing it for about 10 years and they have not cracked the nut. But they have high volumes of unbilled messages. We may be having lower volumes of messages we can bill for, but I encourage you to think hard about the structures. The last thing I'm going to talk about is readjusting the allocation of time to create access. And here we're going to come back to messaging as a powerful tool. So think about what types of visits can be streamlined and what types of visits can be expanded. So using virtual care to expand, make better use of in-person and other types of care. So here's a hypothetical patient. Imagine you've got a list of all your patients with different chronic conditions, hypertension, coronary artery disease, diabetes, CHF, etc. And you are tracking a bunch of physiological parameters on an ongoing basis. And you can flag things when people's parameters are outside of a given range. So for Martha Jones, who's 55 and has hypertension, her blood pressure came up as 160/95. She's on hydrochlorothiazide and amlodipine. You've already agreed that, if your medication is elevated, she should increase her amlodipine to 5 milligrams. So either you send a message or maybe a team member sends a message to the patient to say, please increase your amlodipine to 5 milligrams. So you could extrapolate a whole bunch of 5 to 50 to 30 seconds to 2-minute interactions for a wide range of problems that are kind of relatively algorithmic. The time you save with that could then be allocated to a patient like this, Mr. Jorge Diaz, whose goals of care are to attend his daughter's wedding, to go to church, to go to a baseball game and see his sister. In order to achieve his goals, he needs to have a certain level of function. So here, we think of function in his case in terms of urinary continence, which he reports using a symptom score asynchronously. His energy level, he reports a fatigue symptom score, and his mobility, which could be tracked using the time up and go test. Now you have a sense of his function. You could look at his illnesses. He's got congestive heart failure, COPD, sleep apnea, diabetes, and prostatic hypertrophy. And he could again submit symptom scores. So you get a sense, using the COPD assessment test and other tests to see how well his symptoms are controlled. In a visit, you could look at function and illnesses, his symptoms, make decisions about what medications to change. You could even track how his caregiver, how the caregivers are doing. His daughter Stella, who's stressed out because of her upcoming wedding, and the son who's taking it easy. And so you could imagine an in-person visit where you've collected all of this information ahead of time and you're tracking it such that, in 20 minutes or 30 minutes, you could achieve a wide range of things for a very complex patient. So, I think virtual care, if it's strategically deployed, could help reallocate your time to provide a different type of access for people with different needs. So the last thing I'll say on access is that your access will depend on how comprehensive you want to be. You could provide very rapid care to lots of people, providing good access in a timely way, but not being comprehensive. One of the things that was built out during COVID was, because often we had poor access to specialists, we would be looking stuff up on UpToDate. We would, have services. So in Ontario, we have a service called the Scope service where primary care doctors can speak to an internist or a radiologist or a nurse navigator to get information or e-consult and e-referral, or e-consult in particular, which are again services that are increasingly more and more widely available across the province. So these tools allow us to provide more comprehensive care, which again can provide better access. So the last thing I'll say when we, thinking about workload is how can we use various tools to reduce our workloads, increase our productivity. So number one is the area of education. So having tailored resources, having ready-made tools that we can point people to, videos, and a wide range of things that would reduce the amount of time we spend explaining things in a visit and provide reliable resources for patients after a visit. Focusing on building capabilities, so understanding what do patients know and what can they do, and what can caregivers do to expand the amount of care that they provide. I think this has always been true. But I think going forward, focusing on education and using virtual means to enhance education is something that could reduce ongoing demand for care and help us manage larger panels and provide better access. Monitoring and support, I touched on this in that kind of dashboard, but thinking about how do we routinely collect key parameters. There are a wide range of things that we don't need to collect in person and that patients could upload into the chart, depending on what tools you have. Providing behavioral nudges for people is not something that's widely done, but again, could be done to encourage people to do physiotherapy, to check their blood sugars, to do a wide range of things. And then anytime we do monitoring, we need to define thresholds for escalation and then think about next steps in management. So many elements of care could be passed on to patients. Management of hypertension and a wide range of things in the appropriate patient who has high level of activation and education. So, in conclusion, I want to say that access to care is actually at a not an all-time low, but at a it is at a low. We have enormous constraints on us as providers. There is enormous demand that is unmet. I think that health systems are stepping up to provide a wider range of entry points for care, and digital front doors of the type that I had described. And digital tools will help us increase that aspect, make that more productive. And the other thing that digital tools can help us do is go much deeper onto, understand our patients in deeper ways, because we can collect wider range of information, ongoing information, to make more sound and complete decisions. And we're able to reach out to others for advice and provide a broader scope of care. And if we build, using the appropriate tools, and we think about not only how do we provide care for individuals, but how we can provide care for populations, we would be able to do this on a much larger scale. And I recognize some of what I showed you is hypothetical, but many of these tools are in development, and some of what I showed you is still a work in progress. But I think it is the future, and I think that we are getting to the point where the information revolution is coming to healthcare, and we're getting past the point of that productivity paradox, where we will be able to use the tools we have to provide care to the entire population. Thank you very much. Now, hopefully that will have generated some questions for the broad group.
If anybody has any questions, please feel free to type them in the chat. I will actually say to you, Dr. Bhattacharya, I found this absolutely resonating with me personally. I have an elderly father. I have 2 children, teenage children, and my life is, other than work, I'm always they come to me, my children, for example, will come to me and say, I have this problem, I have that problem. So I now have to make doctor's appointments and take them to the doctors and so on and so forth. And children have various situations, and so you're running to the doctors consistently. So I can see where that mobile messaging would help eliminate myself from having to make the appointments, calling, taking the children out of school, making that appointment, waiting for the appointment, and just being able to have the things just more effortless on that aspect. But I also see how messaging can be utilized in an unproductive way as well, because you're going to have people that are, for the lack of better terms, kind of hypochondriac, where they have a little bit more of a, oh, I have this owie, and I have this thing, and I have this thing, and so it's more of a burden on the doctor. So I definitely see that as well. It's very interesting. And the last point that you made about the monitoring, just relating it to my scenario, my father was constantly in and out of the hospital. We had the ambulance continually come to the house, and because he has congestive heart failure, and so he was always having. So they ended up giving him a tablet to monitor all of his signs and make sure that his high blood pressure and his low blood pressure and his this and that. So it's very interesting to have those tools. We just need to figure out how to utilize them to the fullest extent without overburdening the clinicians. Very interesting.
Yeah, so it's all of these tools reduce friction in interactions. And because email is so easy to send, people constantly send emails. Like, knowledge work has been transformed by email. So I think this is it's something that has not yet come to healthcare, but is coming. And part of it is, I think we need ways of triaging messages. There are a wide range of types of messages, and if we can't triage them to the right person to address, whatever the need is, we're going to be in trouble. We're going to, increase the volume. I see there's a question here.
Yep.
So from an evaluative standpoint, are there key indicators particular to risk and standardization scope you suggest need attention? Yes, so there is, it's interesting when we switched to phone consultations early on in the pandemic. It took a little while to determine what is an appropriate assessment remotely. And in the absence of any visual stimulus or visual information, what is an appropriate assessment? We have yet to do that for messaging. The liability concern was mentioned by a dermatologist who's looking at a fuzzy image and trying to say, well, I can't make a diagnosis off this image. I'm gonna have to go back to the patient. So there's, I guess, two types. One is what is the requirement for the quality of information in a message? And you may obviously need to go back and forth multiple times to get the right information. And then what is an appropriate time frame for response? Many people, respond to messages within minutes, but like in healthcare, we never respond within minutes unless we're in the trauma bay or, and so there's a challenge in terms of defining that. So I would say in the messaging space, we have yet to define it. But if we're going to set up billing codes later, next year, we need to get on that. There's a question from Bailey, from Shoppers. Nice to hear from you. So comparing access and virtual in different countries. So yeah, it's a very good question. You're right. So Germany is not on the cutting edge of virtual care, but has higher, very good systems for access. And they are not mutually exclusive. I would say some health systems have invested more in some things than others, right? So I'm just trying to go back to that regular place of care, the after hours arrangement, hearing back from the doctor. Yeah, so Germany provided feedback on the same day. 6% of people said that they rarely heard back from the doctor on the same day, which was by far the best in the sample. But in terms of some of the other parameters, you're right, it was they were not as good. So I think part of it is how primary care is organized. I mean, there are places like in Holland, the attachment rates are 100%. So everyone has a family doctor. That family doctor has after hours care and has a kind of an organized system for providing care. So are we delivering a bunch of inappropriate virtual care? I would say we are delivering virtual care within models of care that are not great. Basically, we have a subset of people who, have, subset of patients who are attached, who have modest access to care, and then a whole bunch of people who have, don't have access to comprehensive care. So I'd say, yeah, virtual is just part of it. I mean, how care is organized is an essential part of that, and you made a very good point there. Question on the policy perspective, pre and post-pandemic funding changes. So I haven't followed this in every province and territory. I will say in Ontario, we provided funding for virtual care at par during the pandemic, and then they switched to sort of separate ongoing, like virtual care in the context of ongoing care, where you're billed at par for video and close to par for telephone, but for walk-in type of care, then it's billed at a much lower rate. And so what did that do? Well, it changed, dramatically reduced the scope of walk-in virtual care. So Maple and Rocket Doctor and many other groups sort of shifted away from direct-to-consumer virtual care to employer-based virtual care because it wasn't lucrative anymore. Because the billing rates were much lower. I think within primary care, comprehensive primary care, it hasn't changed that dramatically, but basically we have seen a decline because of the shift in the billing. I will say I haven't seen the shift between from phone to video. I haven't seen that data yet, so I can't comment on that, but there was differential billing included.
There is a question that came in from the Q&A portion. From Margot Wilson, excellent discussion about what what about liability and how to reduce the HCP provider's liability? And that might have been something mentioned in an earlier question, but.
Yeah, so I think that the only thing I would say on liability is that we need to determine what the responsibility of the provider is, and what is the appropriate time frame for responding, and whether we are responsible for developing triage systems that allow us to determine what's urgent and what's not. That would go beyond, I think, what is asked of doctors currently, but that's something that I think we need to explore. So I think we are introducing a new type of liability, and maybe the scope of what a billable virtual visit or billable message is might help constrain that. It is, yeah, we're going through growing pains in this area. Okay, there's another question from Lee here. Thinking about different models, having a nurse in person is providing physical assessment and relaying that information to a GP. Other factors such as this. This being a health authority service that employs NPs and RNs, and then physicians who are independent practitioners. How do you attend to some of these complexities with respect to risk and accountability and liability and appropriateness of care? That's a great point. There are models. So there's a model in Ontario in Renfrew County that has provided, it's called the Integrated Virtual Care, or VTACS, Virtual Triage and Assessment Center, where people call into a number, they receive, they're responded to by a medical office assistant. That medical office assistant often passes them on to a doctor who's remote, and that doctor will address a wide range. About 92% of the requests are managed on the phone, and in a subset of cases, they ask the patient to come in to get an in-person assessment, in this case by a paramedic or a medical office assistant with a physician remotely, so like with an electronic stethoscope or an electronic otoscope. But there is, there's RN variations on that model. And so what is the risk and accountability for a physician who is remote? I unfortunately, we need to go to the CMPA on that one, but I would say this is routinely done already. And whether it has been sorted out or people just do it and hope for the best, I can't say. But there are many models that use this mix of hybrid in-person and virtual to extend the reach of a physician to collect information in person that they aren't able to get on the phone.
We have one more time for one more question. You want to answer that one?
Yeah, so have we tried using bots to provide initial answers? So yeah, so the messaging, like the volumes are going to be probably substantial once this gets going. You're going to have to differentiate between billable messages that are clinical in nature that lead you to make a diagnosis or clinical recommendation, and then the clerical messages. Your clerical staff may very well say that the clerical messages are time-saving compared to transcribing phone messages, which can take up to 2 hours a day apparently in some practices. But the extent to which we can tag messages, collect markers, dispatch them, prioritize them. There are functions within advanced EMRs. I think Epic in the US is working on this. And this is an area that I'm not sure how developed it is currently. I think there are people experimenting with it, but it is essential to doing this well. And can we standardize the message for RN physician response? For sure. There is, I'll just say one last thing. There are models of care that are messaging only. There's an older one called Sherpa, and they have libraries of standardized messages that are just slightly tweaked and used to standardize interaction and automate certain types of interaction to make it easier. So I think this is a new frontier. We may be opening the Pandora's box slightly prematurely, opening up messaging before we have those. But this is something that I think is essential to enhancing productivity in these areas. Thank you all for a very robust discussion. I'll hand it back to you.
Thank you so very much, Dr. Bhattacharya. This was such an informative presentation. I think everybody will agree. I hope you all enjoyed the webinar today. I am going to share my screen for a moment. And I'm going to launch a poll, a satisfaction poll. If you all can take a very quick moment to, it is on the screen now, to answer, that would be lovely. Thank you so very much. And we have launched our community platform. I encourage all members to log in and start or join a discussion. All Webinar Wednesday recordings, including this one, will now be located on our community platform. This has been recorded, so we will be including this on there. And we have upcoming events. We have February 6th, Calgary Winter Conference, our Ahead of the Curve, and our Up on Digital. Registration will be opened very shortly, but we do hope that you can attend. If there's anything that else with regards to any other questions, because I do see some in the chat, if there is anything that comes through, I will forward them on to Dr. Bhattacharya. Thank you so very much to everybody for being here today, and a special thank you for Dr. Bhattacharya. Thank you.
Thanks, everyone. Bye-bye.
Bye-bye.